Yeah,
So
I think they also really have preclinical data suggesting that these drugs can be potentially synergistic. So I agree, you know, a brilliant kind of a combination, and really kind of getting back to what we talked about early. This could be a very important combination of agents for patients who are not eligible for a transplant or even have failed a prior transplant, don't you think?
yeah, I do. I think that it's clearly less toxic. So giving it to these relapsed and refractory patient populations, kind of no matter what your niche is in terms of that, you know, which of the relapsed refractory patients. But I think, you know, particularly in people that aren't eligible, or you don't think can withstand a, you know, CAR T cells, then using this drug and this therapy, I should say, because it's combined with lenalidomide, I think it has a lot of potential without just sort of continually beating on people with chemoimmunotherapy. So I think you know, that's certainly a huge potential for patients.
Yeah,
The
I agree.
sure, go ahead, John.
No, I agree. I think that, you know, the idea that you're, or understanding when you're resistant to chemotherapy or refractory to chemotherapy, as you say, continuing the same thing doesn't make a lot of sense. And I think this is potentially a really nice salvage regimen, even for those people that you are going to take to a transplant, if you can, meaning those people that have had a reasonable first remission or something like that. Where do you see it fitting in?
Yeah, I do. I think that that might work fine. I mean, one of the things that, well, the whole transplant world is changing, right? So we have these numerous different trials ongoing about, you know, from Zuma 7, Belinda, and others looking at whether we're going to replace transplant with CAR T cells, and so move CAR T cells to second line. One of the issues that I think about in terms of transplant sensitivity in the past, it's always been chemosensitivity, since you're just giving higher doses. And so I think in the beginning, I might, you know, at least continue to use a chemoimmunotherapy as a litmus test about whether someone should have a stem cell transplant. But if I'm not going to transplant, or if they failed a salvage regimen, and you didn't think you could take into CAR T cells, then I would probably use this. One of the things that I trying to wrap my head around and you know, and figure out how to sequence is that this is CD19 therapy, and as is to most of the CAR T cells, at least all the commercially available CAR T cells today. So there's certainly a concern that using a CD19 therapy, you might downregulate the expression of CD19 and then perhaps make CAR T cells less effective. So if my goal was CAR T cells, I think at least until we know more, I probably wouldn't use this as a segue to that. What's your thinking?
You know, we don't have enough data, so I agree with you. You got to really be cautious, and I'm glad you brought that up. You know, there is some anecdotal data saying that you can get the MOR208 and then proceed to a CAR T cell therapy. You know, that's anecdotal, so you're right. We need to wait for data. I agree with you completely. But I'd also point out, you know, we had this same concern in the acute lymphoblastic leukemia space, where we were worried about being able to do CAR T cells in patients who had had prior anti-CD19 based therapy with Blincyto. And we found that, you know, it probably doesn't affect the CAR T cell approach or the outcomes. Let's see what happens here. I mean, I agree with you. I'd proceed with a lot of caution if you're trying to get to a CD19 directed CAR T cell therapy. For me, I think this is what I think you really were saying. This is a salvage therapy for people that don't have great options otherwise. And the ASH data that was presented in 2019, I think was really, really valuable to see. We'll have to see the longer data and the upcoming randomized data. But that early data was pretty encouraging, I think. And I wonder what you think about that.
Oh yeah, I agree with you completely. So, you know, just to remind everybody, this is the L-MIND study, which combined lenalidomide with MOR208. You know, the MOR208 was given, there's a little bit of a load, and then it's given weekly, and then it's given every other week for about a year, and then and that's combined with lenalidomide, which is, I think, given 3 weeks out of 4, and then ultimately, if if patients made it to a year or more, they could drop out and no longer receive the lenalidomide and continue on the more 208. I would thought the results were really impressive. There was, I think, about 60% or more patients responded, many complete remissions. There was some very durable remissions from this group. So I thought that was, I was surprised, right? I mean, I wouldn't have thought that the results would have been that good.
I was pretty impressed with it too. As you said, the response rates were in a difficult patient population. These are people that we're not going to get a transplant delivered to. They had up to 3 prior therapies, if I remember right. And as you noted, the response rates were about 60%, and about 30% or a third of patients had a complete remission. And the progression-free survival was almost a year and a half in relapsed or maybe even multiply relapsed large cell lymphoma. That to me is extremely encouraging. And I even am more excited about the fact that so many people get a remission, that if you looked at the people that got out, I think about a year, about 3/4 of patients were still on therapy, maintaining their remission. So you got to get, of course, as many people to respond as possible. And of course, understand that, there are toxicities with the agent, which we should probably talk about. But I think the L-MIND data was really important for us to understand that we have some options now for using this drug in those patients.
Yeah, no, and I think I was impressed also the fact that these patients, the follow-up was actually pretty mature, right? I mean, I think it was almost a year and a half of follow-up for most of these patients. And so in large cell lymphoma, that's a relapsed or refractory large cell lymphoma, that's almost an eternity, right? So I thought that was good data as well. I thought the adverse event compared to chemoimmunotherapy, the adverse event profile was kind of what you would expect, right? I mean, you get some of the side effects of the antibody. A lot of it's the lenalidomide, but of course you have to keep them as a pair here. Anyway, I thought that was impressive.
Yeah, actually, you have a fair amount of experience with it. From my experience and really understanding the data, surprisingly, perhaps the infusion-related reactions were almost zero with this engineered antibody. Perhaps, a bit surprising. There were only, I think, 80 or so patients in the trial. But regardless, if it's close to zero, that's telling you that the antibody is pretty well tolerated. And I think you're right, the adverse events were really hematologic. There was about a third of patients who were neutropenic or so. There was some thrombocytopenia and anemia. But, when you combine it with the lenalidomide, that's probably not that surprising. And maybe a lot of that was contributed to by the lenalidomide. And if I'm not mistaken, if you had to approach patients with a cytopenia in the trial, they would actually have a dose reduction of their lenalidomide, and they actually did very well if that happened. My experience with this kind of combination is that the lenalidomide dose may be too high. I think you're supposed to start at 25 milligrams daily. What do you think about that?
I mean, John, I agree with you regarding the dose in terms of if we extrapolate from the R² regimen, it is hard to get some of these higher doses of lenalidomide in, and so perhaps dose adjusting based on toxicities is important, or even maybe starting out at a little bit lower dose. I guess the other thing that's important to this data set is you look at all the different subgroups. It really didn't appear that there was a subgroup that didn't benefit from this. I mean, of course, the subgroups are small, as you mentioned. This is an 80-patient trial so it's hard to know if you dial down to really small subgroups, but they all seem to do pretty well.
Yeah, let me just say, I agree, it's small numbers, but, those included the patients with more refractory disease, patients with higher IPI scores, patients, of course, refractory to rituximab therapy, and a variety of other treatments. So you know, that's getting back to where we started to say, you know, those are the patients where we have a huge unmet need. And perhaps it's not surprising that it works even in those more aggressive patients because it has a completely different mechanism of action from cytotoxic chemotherapy that we have been using in this kind of setting for so many years. I hope we continue to get, you know, data that really convinces us that those more aggressive patients benefit because, again, we have a major unmet need there, I would say.
Yeah, no, I agree on that.